This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
In this episode of the 1 Million Live podcast, I had the pleasure of speaking to Stefan Davison, who has the role of the Blended Digital Learning Lead and who is also a paramedic clinical tutor, and also with Tom Cutting, who is the digital coordinator, both working within the London Ambulance Service Education Organisation. My name is Bjorn Egeland, and I'm your host in this episode. It is a massive job, not just to ensure that the service is operational and that the general population gets the help when needed, but also to ensure that the personnel keeps their skills over time and that new candidates for jobs in the services are well trained. And that is what we will talk mostly about in this episode. However, to set the stage, so to speak, especially for those who do not know London Ambulance that well, I asked Stefan Davison to start by telling us a bit about this ambulance service.
We work for the London Ambulance Service, which is one of the largest pre-hospital providers apparently in the world, but definitely within the UK. So we serve the capital city of London, which, looking on a map, we are encircled within a massive motorway called the M25, and we deal with every patient that's within that, which consists of 3 different airports, lots of tourists, as well as the people who live and work here on a daily basis. On a day-by-day basis, we receive about 5,700 daily 999 calls, which is our emergency calls. So similar to in America, your 911 calls, or around Europe, your 112 kind of emergency calls. With the National Health Service, we also have the non-emergency and urgent care number of 111. And they receive about 6,000 calls a day. On average, it's about 3,000 patients physically either treated or assessed over the phone and dealt with on a daily basis. That will vary from day to day depending on events such as New Year's Eve or major incidents. Sporting incidents might actually reduce the amount of calls and patients we see, just as people are distracted doing other things. The main kind of calls we deal with is about 230 to 240 calls per day for patients in the demographics of either falling over, breathing issues, or chest pains. We only actually deal with about 28 cardiac arrests per day, and we deliver approximately 4 babies without a midwife assisting us per day as well.
4 babies?
4 babies per day, and that is just the ambulance crews will deliver it, and the only ones that we count as that is the ones that are nice and healthy. We seek advice over the phone, and then we can leave them at home to be assessed by the midwife and the health visitor over the next week. And so that we're the only clinician that was involved in the delivery.
You're much more than ambulances and the odd helicopter. You were also on motorbikes and on bicycles. I even saw an emergency situation at Heathrow, with a person with a bicycle just came around the bend with his stuff to take care of a ill patient. Why have you seen the need to use motorcycles and bicycles?
Yeah, so London is a unique challenge, because from one street to the next, you might be getting anything from a 3-lane motorway down to what is essentially a dirt track, and you'll not have any idea until you turn down it. Things like width restrictions. But then you put in the entirety of the population that lives in London. If they're driving the public transports or the buses, a lot of the new electric bikes, there's just so many extra challenges for us to physically get our ambulances through. It's quite a big Mercedes van that we try and drive, so to get it through the traffic, it can be difficult. So to meet the most critically unwell patients, we actually have, so on average on a daily basis, it's 20 bicycles, and that will be things like Heathrow Airport, because they can cover the full from Terminal 1 all the way through to the other side of Terminal 5. They can get there quicker than what I can get out of the car park. because they do move. And people move out of your way when you're going that quickly. 10 motorcycles, and they tend to stay around central London because of the high volume of either tourists or pedestrians, but also then the traffic, pedestrianised streets, they can just get there that much quicker. And that's why we do put out those 80 response cars as well, because even on the normal roads, they're going to be able to squeeze themselves through and get there. So we can start that treatment so much earlier, especially again on the most critically unwell, or on the other side of it, if we've got someone who maybe isn't doing too well with their mental health and is threatening to throw themselves into the Thames, it's the last place you want to be. It's not the cleanest river in the world. And so they can get to the scene and support the police and do like a joint response and support each other to help the patient the best we can. On a daily basis, we tend to put out about 400 ambulances, which will either be staffed by emergency medical technicians and or paramedics. They are backed up by about 80 different fast response cars where you'll have a solo paramedic in it. What myself and Tom do, we are the digital team for the education department, and we help with the training of everything from our 999 call handlers, the emergency call handlers, the non-emergency call handlers on 111, and then our emergency medical technician direct entries who do an upskill course all the way through to paramedic. We do have a partnership university because all of our paramedics in the UK hold a degree very similar to the way that nurses have to hold a degree. And we actually have some of our paramedics go into advanced paramedics, and they actually get their doctorates, and they do a lot of the out of hospital doctor level skills as paramedics. But we do also get supported a lot by the helicopter emergency team, which is the helicopter with 1 or 2 doctors on it responding to the most critical, usually trauma jobs, where they can do all of the emergency department treatments, but at the roadside immediately rather than having to travel in. Because where we do have a lot of hospitals in London, actually getting to them because the volume of traffic, it can take just as long as being in a rural area, even though you're in the centre of the capital. My role is to try and bring more of an immersive digital element and kind of move away from learning everything from a textbook and PowerPoints and try and make it interactive, with it being an interactive job, change how we actually assess people formatively and summatively. So having a nice practice and formative, being able to give good debriefs, good feedback, and then implementing an assessment method which is valid across the different learning styles to make sure that the clinical level of people that we're actually putting out there on the road is the best we possibly can. And Tom creates the content for that.
Did you say that leading paramedics is actually they will have a PhD?
Yeah, so our advanced paramedic practitioners is what we call them, but essentially they go away, they do their PhD, they get the doctorate, and they do a lot of the extra medications. They've got different patient group directives. They can give a lot of the in-hospital doctor-only or consultant-only medication, but at the roadside, we have 2 different versions of it. We do specialize in critical care, and they do all of the trauma kind of cases, cardiac arrest, doing ultrasounds to see how viable a cardiac arrest is, or if it is futile, unfortunately, making that choice without having to seek any further assistance from anyone. And then we do have our urgent care, which might be able to do things like relocating fractured dislocations at the site of a football pitch. They may be able to actually go out, diagnose the urine infection and prescribe the antibiotics to save the need for any GP, general practitioner, getting involved, so our normal doctors. Or if it's going towards a sepsis level of illness, actually we can stop the hospital admission and stop that risk of taking them to a further infection site and treat them at home much quicker and more efficiently.
Tom Cutting, tell me, how long does it basically take to become a paramedic in working for a London ambulance?
So at the moment, we've got a couple of routes that you could come in, but what we're pushing for at the moment is through our apprenticeship scheme. So you have the different levels of frontline staff. So you could walk in tomorrow and apply to be an assistant ambulance practitioner with no clinical background. They come and do a course at one of our centres. That could be 8 to 10 weeks. And then they go out on the road and learn their skills and build up a portfolio. and get road experience. And then we've got courses to upskill in-house. So from that, you can then do a technician upskill course. These will take a varying amount of time, but, a year and a half, maybe a couple of years. And then once you become a technician, do the same process. And then with our partner university, then you can upskill again to a paramedic role. So overall, in the apprentice route, coming through London Ambulance, you're looking probably about 6 years if you did it really quickly. And that is, you're paid on the job and you get the support and the learning through our centres. And that's really, we've seen that as a real benefit, especially for the younger staff as well. Getting some life experience. Obviously, you can do the more traditional route over here in the UK. We, like Steve said, doing a degree at universities. So we're partnered with a lot of nearby universities, St George's, Surrey, Oxford, things like that. And they will run their paramedic course for 3 years. And then during that course, you can also do placements with us. So if you're on a course at a university, you get placement days with crews out on the front line, a third man. So, you've got your typical 2-man crew, a third person observing, and they get signed off on their skills as they study their degree. So you've got a couple of routes there. So to become a fully fledged paramedic. We also have a lot of intake globally. So what we offer in our education centres is the newly qualified paramedics. So they come to our centres in London, and we need to Londonise them, for a better word. So we need to get them used to our equipment, our processes, because we're not rural or in other parts of the UK. It's a very different environment for a lot of people who are trained in British universities, and also obviously abroad, Australia or other parts of the world. We have people in Canada, Europe, Africa who've come over. We need to train them for 3 or 4 weeks over here, specifically as London, to sign them off to work as a paramedic, and then they go through a period of being a new paramedic for a year or two until they get signed off.
Before we started this recording, we talked a bit about how you trained people, both new people, which you have presented well, Tom here, but also people who are already in the service. I guess you've seen a lot of changes in the way you yourself have approached this challenge over the last 4 or 5 years. Can you tell us a bit more how you involve them in training? How do you motivate them, and how do you actually do it?
So since we've had these new centres, it's been about 3 or 4 years, we've got some great facilities. So over both sites, we've now got 4 full immersion rooms. So that's projecting videos onto the screen of potential scenes, like a particular roundabout that might be quite hazardous and known to staff. So we can recreate even like a busy environment. So for instance, like the Notting Hill Carnival is quite a massive event in London with loads of people, 250,000 people, maybe more, crowd into a small area. And that's we can take videos of that and replicate it in these immersion rooms. So new staff who are not ever seen these environments or until they go there can get a bit of a dress rehearsal. So they can come into the immersion rooms and get a feel for everything. With existing staff as well, a lot of them probably don't encounter many things. The day-to-day can be a little mundane, shall we say. They're not going to encounter so many of these major events. So in the sim rooms, we try and replicate that and get a feel for it. And the very life-threatening situations that you might not come across, we really try and emphasize, because you need to know the processes, and they might not have done that process for a long time. So if you have an experienced paramedic on the road, they come in for their yearly training, their mandatory training, they need to refresh on skills. So using the immersion rooms and our other skills rooms, we can simulate practices and try and engage them rather than have a little checklist or a little team huddle where they discuss it. Try and really put them in the room with everything else. I mean, traditionally, before we had these new centres, you did have that blue mat in a room with quite a low fidelity mannequin, and people going, right, he's got a major trauma, he's broken his leg, you've got crowds around you, and I think for especially the experienced staff, it's hard for them to get engaged in that. So that's what we try and do anyway.
You're listening to 1 Million Lives, a Laerdal podcast.
So you mentioned, Stefan, that you have a very high number of cardiac arrests, and at least from the outside, sounds like a high number of children getting born every day, even though it was just a question of 4. But with so many staff on board, that doesn't really mean that the average paramedic come across a cardiac arrest or a birth, for that matter, or a trauma on a daily basis.
Not at all. So I actually did the in-house route of training and upskilling. So I started off as a call handler. I then became a emergency medical technician and then did the in-house paramedic upskill and got my full degree, and before becoming the digital learning lead through the tutoring route. And on average, the average paramedic might see 1, maybe 2 cardiac arrests within a year. I do have some colleagues who in a 7-year period have never actually attended a cardiac arrest. I've had other colleagues where it might be every single shift they do, and it is just that case of whichever ambulance station you're based at, because we don't work out of hospitals, we have different stations to try and spread ourselves out ever so slightly more. And then also where you are when that call comes in. There's never really a time when you're not holding a lot of emergency calls or urgent care calls waiting for an ambulance to be dispatched. So there's always a patient kind of waiting for you, but you might go to an entire day of dealing with people with mental health problems, dealing with the same mental health team all day long. You might get a nice variety where day 1, job 1 of the day, you are out there and you go and see a £8 million townhouse in the lovely borough of Chelsea for someone who's just tripped over an awkwardly placed rug. And then the next job is a mental health. The next job is you deliver a baby. Then on average about 6 patients per day, which we refer to commonly as a job, because if we get there and either the patients made their own way, it still classifies as you arriving. We do the legal paperwork and then we move on.
And that, of course, is one of the reasons why you have this continuous education system for people that already are formally trained and certified. They need to have this repeat to get it fresh of mind next time they meet a person which needs a bit more than just transportation.
Yeah, quite a lot of the things that we do is, even if someone still requires to go to hospital, what care can we provide initially? And if you're not seeing these cases, actually, you lose that confidence and you lose that clinical skill as a paramedic. So we do have our normal in-house, the legal mandatory training that we have to do with staff, which is things like cardiac arrests, simple things like moving and handling to try and reduce how many injuries because of the situations we put ourselves in and trying to recreate that in the training environment. We also get a lot of the teams that we work with, so the different stations of ambulance practitioners who come in and do a bespoke trauma day where we'll either do blood all over the place, or we might go all the way back down to just the soft skills of actually dealing with someone who is currently aligning and changing their gender. Or if it's a specific thing, so we had a few years ago a specific training course where we were running it as clinical professional development just for the paramedics. We ended up offering out to all of the other staff on sickle cell crisis because we were increasing the amount of patients who were suffering from a very specific condition. And we did a study with our own research unit within the ambulance service who found out, I think we were only giving about 20 to 22% of them the morphine that they require to actually stop them going into full crisis. So a lot of education around, you might work in an area which actually has quite a low denomination of people who have the crisis, but because we serve the entirety of London, you might start your shift at one side of London and you might end it at the other and then have to drive back. So you might still end up in the area where this is a likelihood of finding it, and doing a just PowerPoint update or a read a policy doesn't give you enough. You need to come into one of the sites. You have to be able to do a training environment and learn from it, because that's the job we do, is the practical learning, and then encourage that reflection and that reflective practice, which in the UK, the governing body, the Healthcare Professions Council, HCPC, they actually require us to do reflective practice about 1 a month. The same way that nurses have to do their revalidation, we can be called upon to provide our clinical professional development to try and display that we're doing a range of environments to actually encourage our own learning and make sure that we are staying relevant and up to date. I will say I initially started with the Northeast Ambulance Service. They do things slightly differently. London ensure that that's always there and force this clinical professional development just through this core skills refresher, we call it, which is your mandatory training. We bring you in and we do these environments where you do that scenario, as Tom was saying, trying to make it a bit more realistic, being able to project things, actually building a little bit of a fake living room and putting someone in an awkward position. People don't tend to fall perfectly in the middle of a room on a blue mat and then go into cardiac arrest. It would make the job a lot different if they did.
Tom, I understand that you have around 1,000 students per year?
So we've got, what was the numbers here? 1,130 students and about 680 apprentices come through both education centres.
And can you tell us a little more, in practice, how do you work with these people? I understand that some of these students are also appointed to lead their own simulation sessions.
Yeah, so what we've tried to do, the numbers are a blessing and a curse, because the amount of numbers we come through, we can see changes in practice on the road. So we try and work with our research team. And because we've got so many new staff coming through our centres, we can see trends. And if there's anything we need to work on, we can try and train it at the start and to avoid any further down the line. So with the numbers, we've got some rooms and space here, but each cohort can be up to 20 people. For one paramedic tutor. So to do a traditional sim day, a full immersion day, we might not have that luxury. So what we'll do to get them all engaged, we try and encourage the peer-to-peer learning. So our simulation management software we use is the Sim Capture. So there's a function on that. Each staff member has a trust tablet or pad that they use for most of their learning while they're in the centre. And we can then schedule skills and learning tools for each staff to complete with their peer. So, for instance, the newly qualified paramedics who come from the universities, like I said before, they already know their skill. There's no real reason for us to, teach them that skill again. All we're doing is assessing and ticking it off so they can go out on the road. So we're using it at the moment. For instance, if you were going to put an eye gel in for an airway, they can film with their peer and then go through the checklist and tick off the skills. And we've found when we've been doing this through the groups that the process is a lot quicker because a tutor can go in and review in the cloud-based system and just cherry pick some examples. Also, peers have been able to highlight a lot easier. They've come forward a bit more. In the normal traditional class setting, people are quite afraid to come forward and go, I don't know that, or I'm not really sure. Whereas the peers, we've noticed them really help each other out, and it's sped the whole process along, and we've got some great feedback.
You are using video recording, among other things, during the simulation sessions, and you are also using data collection. Can you tell us a bit more about that?
So when we record the sessions, whether it be a formative, a practice session, or would that be a summative, we call it, which is the assessment at the end of the week, say, we can then use annotations on the timeline of that video. So in a cardiac arrest scenario, which we run very frequently, obviously there's a set process. So we can there's an annotation for putting the defib pads on the patient, or there's a time when you call for a backup from a crew. And so a tutor or myself will watch that live, and then or even can go back to the video afterwards and annotate the scenario session unfold. So where we're trying to look for data is with our research team, who look out on real life road examples of some clinical failings or something that needs to be improved on. They highlight some key issues for us. So at the moment, we're looking at the defib pads being placed within a certain amount of time. So if you turn up to your patient, it's obvious they're in a cardiac arrest scenario with no danger around them. It should be on as soon as possible. So with the annotations in our sessions that we run probably, a good 20 sessions a day with one cohort, whatever clinical level that might be, if they're a paramedic or a tech. So we annotate the defib pad being placed, and then we can look at the data about the timings of that. If it is within the 2-minute bracket,
I'm not sure who's going to answer this, Stefan or Tom. Let's go to Stefan. Where do you see this going in the future from now? Are you where you want to be, or?
Oh, never. Never is the answer to that. There's always something and something more. So even in my time in the training department over the last 3.5 years, between me and Tom, actually, we're the ones who moved it from paper marking and paper physically writing a timeline and utilizing this fantastic resource, because that was so labor intensive. So the old way was you had one person sitting doing a timeline writing specifically at what time every little thing was done. Now we've got a video recording, which is very specific, but also when you rewatch it back and you've annotated it, you can jump to those points. So if someone does want either specific feedback, or if they do want to contest a pass, professional discussion, fail, what percentage we gave them, you can rewatch the video and you can have a bit of a clinical discussion about it, rather than relying on someone looking up at the right time and taking notes. So the progression we've done over the last 3 years is a really good start, but I do feel that's only the basis. We want a lot more. So we've gone into teams-based working. So all of our stations now have training days built into their core rota. So my hopeful plan, I'm still fairly new in my current role, but my hopeful plan is that we're going to put out a lot of these optional assessments and updates out to the teams and the team managers. So in the sim capture environment you can actually use a mobile phone to dial in and record as well, for either peer-to-peer, or set it up as your own little skills room where they could do either a cardiac arrest. They can go and crash a fake car actually on a roundabout. Most of the London boroughs that we have, so it's kind of split up, and it's kind of like having your own little county right next to each other. They really support us in doing almost everything. They'll close roads for us if we tell them we want to do a big training environment, and put out publicity on our behalf saying, don't panic when you see lots of ambulances turn up, they're doing a training environment. We did one the other day at one of the train stations in central London, and being able to record that and get the data from the real life scenario of, yeah, it did take, say, 6 minutes to get the defib pads on, but that was because the person was actually under the train. That's how long it took until we could confirm the power was off and actually clear the danger element that we hammer into all of our students as the most important is your safety. Actually, how long in theory is that? And is there something we can feed back to the Transport for London who run the underground, that your process needs speeding up slightly because we're getting delayed, which is increasing the risk for the patient, decreasing our level of care.
I read something about something called 10-second triage. What's that all about?
So, as ever, when you have any of the big major incidents, London has had a fair few from the 7/7 bombings onwards. There's always learning that we have, and everything is reflective practice for the ambulance service as it is for the full National Health Service. Some of the learning we got was how long it was taking us to triage, and the tool we were using maybe was a bit too in-depth, and this whole new approach is being created by the National Audit Research Unit, which are in charge of our hazardous area teams. They've made this new tool for us, which streamlines it down, but also makes it more usable by our lower level of clinicians, so we can get the initial numbers of how many patients and how actually sick are they. So for instance, recently at Grenfell Tower, we got heavily criticised for how long it took us to clear the patients that maybe didn't need to wait on site and could make their own way to hospital. So now we have this new 10-second, it's within 10 seconds you should be able to look at someone and know what category are you giving them, which essentially is, if you imagine like a traffic light, we call them 1, 2, and 3, but it's going to be red, yellow, and green. Green is you're up, you're walking, great. If you're up and walking and shouting at me, please keep walking, shout at someone else down there. Yellow is they need a bit of help, but do they need help to get out? Because if they don't, again, go down there, help will be before you. And then we've got our red numbers, which will then be, we have to get someone to help you get out. We'll tell the fire brigade usually, because they're very good at dealing with the horrible incidents we've got to go to and getting people out of the danger zone.
I see.
This was all brought in within a very short space of time, and we had to create how to do it. And it was interesting to see different approaches. So we've had things like doing Lego men, so there's something physically representative so people can see it. We've done, here's some videos of actually what you might walk into and how we're going to do it, and trying to approach it so depending on how you learn, everyone got something from it. We've then started running simulations based on that, so we can physically go. We went to a nightclub in central London where we did it as though a bomb had gone off, and actually how are you going to deal with it? And to get physical frontline ambulance crews turn up, there was about 70 people there. Only 10 of them were actually facilitators. Everyone else was a frontline clinician. And we ran the scenario 7 times through the day. And each time we got markedly quicker and improved our response just from physically doing it and building up that muscle memory. So if it ever unfortunately does happen, we have it. But their experience was then recorded so we could share it with someone else, and the learning could be shared by everyone who couldn't make it or wasn't able to make it on that day.
Someone told me that you got a Gold Learning Award. Tell me about that.
Over to you, Tom.
We got put forward in 2023 and 24 to the Learning Awards, and also another awards, the Adult Learning Awards. So our apprenticeship program, which we mentioned, so that's for the entry level that come to our centres. So that got a silver award, and then the apprenticeship team got the Apprenticeship Employment Gold Award. So it's being recognised. So it's nice to get these things, just to know we're heading in the right direction and we're doing the right things. And also it gives a chance to collaborate with other ambulance trusts around the country, seeing what they're doing. They've been recognised at these awards as well. But we're hopefully leading the way, or getting there anyway.
I would like to thank both Stefan Davison and Tom Cutting for joining us here at the 1 Million Live podcast, talking about London Ambulance Service in general, but also, not least, about how they organise their training, both for newcomers, but also what they do to help the staff maintaining their skills and to learn more. I would normally expect to hear about high numbers of cardiac illnesses, traumas, and other classical emergencies, but the fact that every day an average of 4 children are born in ambulances in London and tended for by personnel from London Ambulance Service without there being a midwife present blew my mind. 4 per day, that is 1,440 per year. Wow. Thank you all for listening in. This episode is also available as a video on selected channels. My name is Bjorn Egeland, and I was your host in this episode.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.